Hello, my name is Kevin O'Brien. I'm Emeritus Professor of Orthodontics at the University of Manchester in the United Kingdom. I've been asked to talk about our new paper, which is due to be published in the June edition of the American Journal of Orthodontics. Normally, I would be using the full facilities of a university's audiovisual department with all the sophistication that brings. However, like the rest of the world, we are currently in a lockdown, and the only way that I could think of doing this was to do a Zoom presentation and make a recording. So I'd just like to share my screen so that I can get up my presentation. And I make myself look a little bit bigger here. So our paper is called "Do Malocclusion and Orthodontic Treatment Impact upon Oral Health?" We did this study to really discover if there was an association between malocclusion and oral health and the effects of orthodontic treatment. And we did this really because we wanted to try and update the evidence base behind some of the indices of orthodontic treatment need, and specifically the index of orthodontic treatment need, which we wanted to perhaps make more up-to-date and more sophisticated to reflect the relevant knowledge of orthodontic treatment. So in order to do this, we carried out a systematic review. It was divided into two parts. Part one looked at the impact on oral health of malocclusion, and part two looked at evidence on the effect of malocclusion on oral health itself. These were two distinct questions that we wanted to answer. We first started by looking at the WHO definition of oral health, and this is fairly straightforward in that it says oral health is the ability to speak, smile, chew, swallow, and convey emotions through facial expressions with confidence, without pain, discomfort, and disease of the craniofacial complex. In fact, this encompasses most of the effects of orthodontic treatment on oral health, and also the effects of malocclusion, perhaps harming oral health. So we carried out our systematic review using the normal methods of an electronic hand search, data extraction, and quality assessment. And in effect, this is what we found. First of all, when we looked at the effect of malocclusion, we found 87 studies that had evaluated this. The only association or evidence that we found was that there was a clear association between overjet and trauma. The greater the overjet of a population of patients, the higher the incidence of trauma. However, we didn't find any other clear associations for caries, periodontal disease, and quality of life. Looking now at part two, which was the effects of orthodontic treatment on oral health. It was much more difficult to find studies in this area because really we needed to have studies which had really measured the effect of orthodontic treatment against an untreated control, and there certainly were very few of these. We found essentially, again, reflecting the first part of the study, that the correction of overjet reduced the probability and the incidence of trauma. However, we could not find any other effects of orthodontic treatment with a degree of confidence that we were hoping to be able to use. So why was this the case? Why were perhaps our results considered to be disappointing? Well, this was really because most research that has been done hasn't really been designed to address the questions that we posed. There essentially were problems with the study design. And in effect, the research, while it may have been carried out very well in terms of methodology, because of the outcome measures that were used or some of the measurements, we concluded that the research may have in fact missed the effects of malocclusion or orthodontic treatment. Importantly, this led us to an absence of evidence, and we must remember that an absence of evidence does not mean that there is an evidence of absence. It means that we have not found any effects at the moment in the development of our research. And importantly, I'd like to underline, this does not mean that malocclusion and orthodontic treatment does not influence oral health. We just haven't used the right methodology or outcome measures to help us answer this question yet. So what are our solutions? Our solutions are to use relevant outcome measures. We need to move away from cephalometrics and occlusal indices and move more towards values that are relevant to patients, such as those that are developed within core outcome sets. So ideally, these values should represent the way that patients feel about their teeth, because that is where I think we are missing the true effects of orthodontic treatment. We need to look carefully at study designs. It's clearly not possible to carry out randomized controlled trials for everything that we do. So we could look at alternative designs such as prospective cohorts, or maybe more sophisticated retrospective studies that don't suffer from such a high degree of selection bias. However, we may not be able to design the ideal study, and in this respect we do, and I would like to underline this, we do need to be rather creative in the studies that we are hoping to carry out so that we may answer these two important questions. I do hope that you enjoy our paper. It was a challenge to do, but we hope that it is of value. Thank you very much.